Good evening, everyone. I think we've got some guests already in the room. I know that Tolakele in the background is still letting some of our attendees in. It'll take a minute or two, but we already have 124 guests. Well, you all welcome to this evening, the 9th of October, for our webinar today. I am Dr. Ernest Kinoshi. Been working in operations in Clinix now for quite a number of years, but and you've seen me before, so I share the hosting with our head of clinical, chief medical officer, who was here with you last week, Dr. Burton Shinas. Thank you very much. Whilst Tolakele is letting people in, I will go through our usual house rules. First of all, Clinix hosts these webinars free of charge every Thursday, or as often as possible every Thursday, and they're free to you, members of the professions. Not just medical professions, but there are also nurses who log in and pharmacists who log in. We also have other allied health professionals who log in as well on a regular basis. But most of our attendees are doctors, roughly 50% of them being specialists from all clinical specialties. Clinical disciplines, and also a lot of general practitioners log in, and we request practitioners, academicians, GPs, anyone to offer to share their knowledge with their colleagues on this platform, and we encourage any one of you who would like to maybe offer yourself in future to share any aspect on any topic that is within the medical healthcare sphere, to academic or not. It could be scientific, could be anyone that we will consider, and we will gladly let you in. So if you'd like to contact us, or you'd like to send a name of someone who would like to share a knowledge on this platform in future, please let us know. Our email address is webinars@clinix.co.za. Webinars@clinix.co.za. Our webinars are accredited with the HPCSA for CPD points, continuing professional development points. So we submit our presentations to them, and the clinicians do get CPD points. When I contacted HPCSA earlier this week, they told me that they have managed to improve their systems to an extent where they no longer take 3-4 weeks to allocate points as soon as the provider, in our case, it's our provider, as soon as we send your information, all the people who had logged in to any of our webinars, to them, they will update your profile automatically on HPCSA. So what we do on your HPCSA profile, so you can actually check it yourself on the website. The other thing is that for people to, for our professionals to get CPD points, and I'm saying this because it causes constant problems, is that you have to log in with your HPCSA registration number. So if you get a link from someone else and you join in, and the link will allow you to participate in the webinar. But because you are using somebody else's Zoom link, second hand or third hand, whatever, the system doesn't know that you have attended. So for us to know that you've attended, you actually have to register on the link that we send. The link takes 2 minutes to fill to complete, and it's got your name, where you work, whether you're a medical practitioner or pharmacist or whatever, and then it asks you for your registration number with the body on with which you've registered. So I think that is key, and then you just click, and within a split second you get your Zoom link via email to join. So let's do that. Whilst we have our speaker today, I'll just tell you about him just now. But whilst the speaker is sharing his knowledge with us, we will mute everyone so that there's no interruption. But whilst he's talking, even whilst he's talking, you will be able to use the chat box to post your questions, your comments, in the chat box, and the speaker will attend to them during the questions and answer session that will follow at the end. If you have, and at the end, we'll also unmute you so that if anyone wants to, would like to put his question or comment orally, they may do so. You just raise your electronic hand, and we will recognize you. Either myself or Tolakelo or Sam in the background will do that, and we will you will allow you to make your comment. Our speaker today is a pathologist. We haven't had a pathologist for a long time. We've got Dr. Michel Le Grange. Michel Le Grange is a microbiologist. He's a medical microbiologist. He works with Lancet Laboratories. Obviously, Lancet Laboratories services quite a number of hospitals, especially private hospitals, and some of them are within Clinix Health Group at Dr. S.K. Matseke Memorial Hospital and at September Hospital as well, and that's where we know him from within the Clinix Health Group. He's got a strong background in clinical diagnostics, which is his field of interest, and in laboratory management, and also infectious disease control, and that's why the topic today is gram-negative resistance mechanisms and their clinical implications. I think he'll also touch on antimicrobial stewardship, talking about resistance, what we need to do. So we will learn all that. This is quite good for everyone who is in the healthcare sector. What is MBSHB in UCT before coming up to do his MMed in microbiology and with the NHLS and Wits University. He also got his diploma in tropical medicine and hygiene, DTMNH, and also he's got a diploma in anesthetics, which he received from South African Society of Anesthetics, John Cooper Medical, following his MBSH in UCT. Over the course of the year of his career, Dr. Le Grange has built extensive expertise through roles at leading pathology groups such as Lancet, where he served as a consultant and serving as a consultant in medical microbiology. His registered training was done, as I said, in at Wits and NHLS, where he refined his skills in laboratory diagnostics and infectious disease control, clinical liaison, and also in antimicrobial stewardship. I think we'll give it over now to Dr. Le Grange. Dr. Le Grange, I'm going to mute myself, and Tolakele will do the same, and then we'll let you do your presentation. You may go ahead, Doc. Thank you very much, and all the best.
Thanks, Dr. Koneshi. I appreciate that introduction. It was a nice trip down memory lane of things that happened a long time ago. I hope everyone will find the discussion interesting and find something of relevance. I'm sure everyone here has had some interaction in their clinical practice with drug-resistant organisms. I'm just going to put my video off so we can concentrate on the slides and hopefully don't use too much bandwidth. And then, yeah, let's get going with the talk. So there it goes. So this is just the outline of the talk. I'm just going to give a brief introduction and background, just that we're all a little bit on the same page, because there's quite a variation of skills and clinical roles, and some of us have done med school quite a while back and don't remember the basics of bacteriology, because we don't use it every day in clinical practice. And then hopefully we'll have something here that's relevant to your clinical practice during the talk. So what is a gram-negative bacteria, seeing that it's the first part of the talk? The gram stain just refers to the color that we dye a bacteria underneath a microscope. That's literally all that it refers to. And these little pink guys are what we would call gram negative. The purple ones are what we would call gram positive. That's all that we see under a microscope. But what does it mean in terms of the bacteria? So these bacteria stain differently because they've got different structures to their bacterial membranes and cell walls. So what here is a bit of a diagram, very simplified, of a gram-negative bacteria membrane and cell wall. And no need to remember all these different things, but just to be aware that these unique structures are what provide some of the resistance mechanisms in these bacteria. So a big target is this peptidoglycan layer. This is where a lot of our antibiotics work on, particularly our beta-lactams, such as penicillins and your cephalosporins and your carbapenems. And so it's quite a protected layer. So things need to be transversed. This membrane needs to be transversed. These special porins need to be gone through. And even when it's in here, there's other membrane proteins to go through. And then some of the targets for antibiotics are within the bacteria. So they've got to get through all of these layers, which really just complicates how they reach for antibiotics to be effective. So now that we're talking about antibiotics getting in, how do antibiotics work? So the main way that antibiotics work is that bacteria is a different domain of life to humans. So we can give an antibacterial molecule to a human, and most of the time it doesn't target human tissues. I mean, that's not an absolute. We all know that because there's side effects. And so it's more targeted to the bacterial enzymes and structures. So I'm not going to go through this list, but just the main places that it works on is on the cell membrane, the cell wall, and then if it gets into the bacteria, it interferes with the bacterial DNA synthesis, or with bacterial protein synthesis, or creating vital molecules for the bacteria to survive, which either causes the bacteria to stop dividing and then the immune system clears the bacteria, or it causes the bacteria to lyse open and basically explode and die. So those are the things. So obviously the bacteria wants to protect itself against these, and so it develops resistance. This hasn't been developed or evolved just simply because we use antibiotics. These are fights that bacteria are having in the environment. So we were a little naive when we introduced back antibiotics, and we thought, oh, we're done. We never have to worry about anything again because the bacteria already had all the armamentarium to create to defend themselves. So there's really four main ways that bacteria develop resistance. So they either modify the target that your antibiotic that you've prescribed is given. So this is in terms of changing enzymes so that the antibiotic can no longer bind. They either produce special enzymes which break down the antibiotics. So this is very common with the beta-lactams and the penicillins. Or they simply pump the antibiotics out so the antibiotics can get in, but as soon as they get in, the bacteria goes, oh, hell no, and pumps them out, and then they're not in the area where they need to have an effect. Antibiotics around the bacteria is not going to do anything. It needs to be at the site of action. Or changes those porins that we showed in the first slide, and the antibiotics can't get in. So these are some of the resistance mechanisms. Then there's some things about the community of bacteria that can also cause resistance. So things like biofilm, which are difficult to penetrate, provides a protective area for bacteria. Some bacteria decide to just not metabolize, and if they're not metabolizing, most bacteria won't work. And these are called persister states and results in antibiotic tolerance despite not having an identifiable resistance change. But that's beyond the scope of this talk, just something I thought I'd mention. So how do bacteria get these resistance? Both of these pictures are representing the same thing. I'm not going to spend too much time on this, but essentially either there's a mutation in the bacterial's DNA, so it makes a different enzyme, and just through luck, because bacteria multiply so much, one that is resistant to the antibiotic comes out, and then that one selectively grows in the antibiotic environment. Otherwise, a bacteria has a piece of DNA that's very helpful, and it's got antibiotic resistance mechanisms on it. And so those that have it give it to their friends. And that's the fastest way that antibiotic resistance can spread. And then there's ways with bacteriophages called transduction. And there's another way called transformation, where bacteria actually just pull DNA from other bacteria from the environment. And if they get antibiotic resistance genes, they can then develop resistance. And so the other aspect of resistance is what antibiotic you give. So we give antibiotics quite regularly as clinicians, but there's lots of things that actually go into our decision making when we select an antibiotic. So what we have available to us, whether we're in the state or private sector, whether there's shortages, where in the world we are. Patient factors, so is the patient allergic to the antibiotic of choice? Do you have to choose another one? The site of infection, not all antibiotics enter all body compartments. So if you've got a meningitis, just because it says an S on a report doesn't necessarily mean that you can use it. We need to have that knowledge. Then these PK/PD parameters, so pharmacokinetic, pharmacodynamics, it's how the body metabolizes antibiotics and how it distributes and excretes, can all impact. Also, all changed in the disease state, which further complicates. And then we're just talking about one component of your antibiotic selection, your antibiotic resistance. So just to see that it's in a big clinical picture that we're talking about. And then, so what does all of that mean in terms of how the lab communicates with the clinician? I'm sure your main point of antibacterial resistance is to see the clinical report and to see S's and R's. So I'm not going to go through all these definitions. I think it's quite late in the evening, and each one of these can be a whole lecture on themselves. And this is really more what we do in the lab. But in terms of what you see, so when you see an S, it represents susceptible. So what does susceptible mean? So susceptible means that you are likely to have treatment success if you give the antibiotic at the recommended dosage. That's all that means. It means you've got a high likelihood of success. And so resistance means the others. The resistance means that you are less likely. It doesn't mean there's going to be no success, but it means that you'll be less likely to have success if you give the antibiotic at the dose that's in the sensitive range. And then we have this on the report that appears that's an I. So it used to be said that this is intermediate. There's definitely been a change in that thought that it really should mean susceptible increased exposure to the antibiotic, mainly because, if we're honest, when people see an I on the report, they treat it as resistant, which has resulted in us using more broad spectrum antibiotics to treat infections or when we don't need to, which helps to promote resistance to those mechanisms. So this is where we come in the antimicrobial steward space to discuss with our colleagues to say, look, we've got an intermediate on the report. Actually, we should be looking at that as sensitive for specific infections and at specific doses. Ideally, this should be discussed with the infectious diseases clinical microbiologist, if you have available clinical pharmacologist, to see what we can do, how we adjust dosing, and how we use these antibiotics, often when we have extensively drug-resistant infections and bacteria. So won't go too much into this, but you'll often hear microbiologists say things like wild type bacteria, intrinsic resistant, predictable resistance. So yes, we are talking about drug resistance, but it's important to remember that some bacteria have a resistance to certain antibiotics, but that doesn't mean they've acquired resistance. That is just a property of the bacteria, and that we call that intrinsic resistance. And so wild type means what we would expect if if a bacteria was never exposed to an antibiotic, we would expect it. This is the antibiogram that we would expect and what it would be susceptible to. So these are all different wild types for different species of bacteria. So E. coli, as you can see, doesn't have any intrinsic resistant mechanisms. Whereas if you come to Klebsiella pneumonia, we've got an R next to this ampicillin. The rest is all sensitive. But this doesn't mean it has an acquired resistance. This is not what we would call a resistant gram-negative organism, because we expect it to be resistant to ampicillin. And then Citrobacter fruindii, we would expect it to be resistant to ampicillin and coamoxiclav, trade name augmentin. So these are not new and acquired resistance. Doesn't require us to phone a hospital to say, do you have IPC measures in place? You know, and so these are as expected. It does so. Knowing which organisms have which type of intrinsic resistance can help you choose your antibiotic. Because if you get a Klebs pneumo and you've given your patient ampicillin, you know you need to call that patient back to either give them coamoxiclav or to change it to one of the other oral antibiotics if you're treating oral. This is just an disc diffusion antimicrobial plature, a picture of that. This is one of the most cost-effective ways to determine antibiotic susceptibility testing in the laboratory. Everything's popping up here. So this is what's called the World Health Organization priority pathogen list. These are the organisms that are expected to cause the most trouble and difficulty in the healthcare field, and where research and development for new treatment modalities should be put. So they've got them in a critical, high, and medium group. Critical group is really resistant to some of our last line antibiotics, so things like carbapenem resistant Enterobacterales, ESBL or third generation cephalosporin resistance, so that's what we call extended spectrum beta-lactamase, and then carbapenem resistant Acinetobacter. So for our hospital colleagues on the call, or if you work in an ICU, these are the bacteria that would give you a headache if you see it on the report. Difficult to choose treatment options, and often require a lot of liaising between the clinical microbiology, infectious diseases, and your pharmacy. Sometimes this is where you have to fill in special Section 21 forms to get antibiotics that are not available in the country regularly. And that's the difficulty. And then being in South Africa, this one's particularly important, rifampicin-resistant Mycobacterium tuberculosis. We're not going to read these all through to you, but then there's the high group. These are ones that can cause significant disease. Again, a mixture of organisms. And then this is our medium group. These are the ones where it will be affecting your empiric normal treatment with potential to cause problems. Just to point out that in the critical group, minus the bacteria, these are all gram-negative organisms, which develop widespread infection. But I think let's start with one from the medium group. Let's talk about Haemophilus influenzae, ampicillin resistant. So off the bat, I mean, Haemophilus influenzae is one of our common causes of community-acquired pneumonia. Most of our treatment for any community-acquired pneumonia caused by Haemophilus influenzae or otitis media, or pharyngitis or anything like that, your treatment's going to be empiric, and you are going to be giving your treatment. And the current guidelines would say to use high-dose oral amoxicillin, or to use coamoxiclav, or even a second-generation cephalosporin such as cefuroxime. So I know this first point that won't really make much sense if you're not in the microbiological field, but essentially what it says is you're not going to get away with treating this with amoxil, augmentin, or cefuroxime, or any of these, if you're giving normal, small, regular doses, you need to give an increased dose to have an effect. So for amoxil, that's 750 to 1 gram 3 times a day in adults. Haven't memorized the pediatric dose. For clavulanic acid, it's 1 gram 3 times a day. There is a slow release product of amoxicillin clavulanic acid on the market where you can give 2 grams twice a day. It has to be that product, which is amoxicillin clavulanic SR. You'll see that there's a product on the market called amoxicillin BD. That is not a slow release one. So giving that 1 gram twice a day is insufficient treatment for this organism. So that would have to still be 1 gram 3 times a day. And then your oral cephalosporins, where you'd have to look at your product insert to see the increased doses. So this is just simply due to the membrane that we spoke about earlier, characteristics of this bacteria. So it's difficulties in getting the amoxicillin in with normal regular doses. But then we developed, Haemophilus influenzae evolved resistance to our first line ampicillin amoxicillin. And this was done with one of those mechanisms, a beta-lactamase, so one of those enzymes which break down the amoxicillin or ampicillin. Don't worry about this in brackets, that's just the name of it. It's just named after the child that it was first found in Italy. You'll see this a lot with the names of the beta-lactamases. They tend to be named after where they were found. And so that was very easy to overcome. We just said, use augmentin. So you would often get a report on you'd say Haemophilus influenzae, beta-lactamase positive. You knew, okay, I use augmentin. And so that was very quick testing, cheap testing. But as more resistance and different mechanisms have come along, we need to do more extensive testing, which is more expensive to the healthcare system. So this Blina, beta-lactamase negative. So this is negative, but it's still ampicillin resistant. This is resistance through another mechanism, which is a change in the penicillin binding protein in the wall of the bacteria. So that means you can't use amoxicillin and you can't use co-amoxiclav either. So that would change your empiric choice. Luckily, this is rather rare still in South Africa, so we haven't. And then rather academically, there's this beta-lactamase positive, amoxiclavinate resistant. We don't see much of this in South Africa at the moment. And these strains would then also usually be resistant to cefuroxime. So now you've lost all your oral options, but besides from cotrimoxazole and fluoroquinolone. So now we have to extend our testing even more. So just how it does have an influence, not only clinically, but also on the finances of the healthcare system. And then luckily, most of these would still then be susceptible to your third generation IV ceftriaxone or oral cefpodoxime. But these must also still be tested, adding to things. So sometimes you'd have to phone the lab and say, have you done extended testing on these isolates? Then I don't know if anyone remembers the introduction of the fluoroquinolones, so things like ciprofloxacin, levofloxacin, Moxie. They were going to solve all our problems. They were broad spectrum antibiotics with minimal resistance. It could be given for anything. It was given for your salmonella, it was given for your UTI, you had traveler's diarrhea, used for prophylaxis in patients getting bone marrow, it was used for your STIs. It was great, it was fantastic. We were in the world of no thinking antibiotics, just give Cipro. And also what was great, it had excellent oral bioavailability, so what you gave orally was equally to IV, so even brilliant from that perspective. But the bacteria were ahead of us, and they very quickly developed resistance, partially also when it was given the initial breakpoints were too high. You can't be too mean on the people that set the breakpoints, because when these antibiotics came out, most bacteria were extremely resistant, and we were extremely susceptible, and we weren't aware that we were dosing at a potentially mutation selecting range. So as resistance has developed, we've lost a lot of treatment options. I'm sure anyone in the STI space knows that it's become a lot more complicated to treat STIs, particularly with this syndromic. your Salmonella typhus, when there's outbreaks in areas like Pakistan or even elsewhere on our continent in Africa, we've had to change our empiric therapy to azithromycin because when these outbreak situations, there's no labs to test for the ideal. So you've got to choose what is most likely to be working. And I'm sure if you work in GP practice or have anyone that's coming with a Campylobacter, and if they've required treatment, you've started with the ciprofloxacin, they don't respond, and then you have to upgrade to azithromycin. Just here to show again, so the ciprofloxacin works on bacterial DNA and on specific enzymes. So again, just those four mechanisms in terms of how resistance has developed. It pumps it out. It either breaks down the ciprofloxacin, or hydrolyzes it, or it even produces a protective enzyme which protects the DNA away from the fluoroquinolone. So it's a recurrent theme in terms of how resistance comes along. Then another one, so H. pylori, another one that's present in outpatient situations, particularly if you're doing H. pylori stool testing, which, because not everyone wants to go for a gastroscope, but also for our surgeons on the call. So, we treat symptomatic patients who have proven H. pylori infections, however you've proven it in terms of testing on the stool or whether the patient's gone for a gastroscope, and we've got it that way. And the favored regime was a regime with clarithromycin in it. Clarithromycin, amoxicillin, and a PPI. Very nice for the patient, very few side effects, a bit of nausea, maybe a little bit of diarrhea, but it was a very well tolerated regime. And then treatment failures were noticed to be happening. Infections weren't clearing. Difficulty with Helicobacter pylori, although it says culture at the bottom here, it's almost invariably impossible to culture H. pylori in the lab. It needs very specific conditions when the sample's taken, which invariably has to be a gastroscope. It has to be rushed to the lab. If there's any delay, the bacteria die. They need their microaerophilic environment. And so this often just complicates. And so then we would change for a quinolone-based regime. I'm not going to go through the details of how to treat, but that's just how it changes. But then fluoroquinolones, we now know resistance is developing, but also there's a lot more side effects that are becoming aware as we've used fluoroquinolones over the many years. So it's not our preferred antibiotic. And so now there's regimes where you've got to go on quadruple therapy, things like bismuth and all of that stuff. So it's a bit out of my wheelhouse, but just to show that how resistance in an organism, even to one antibiotic in the treatment regime, can have quite a lot of cascading effects. And the problem with the newer treatment regimes is that they are less effective than the older clarithromycin, and not something that's we are immune to in our environment. This is a review from 2025, I think. Just a couple of headlines from this is that it showed up to a third of, in some places in Africa, up to a third of the Helicobacter pylori is resistant to clarithromycin. And so then we have to go for these molecular tests to test for it. And these require you to have a gastroscope to get that adequate tissue. I mean, we are looking at doing it on stool, but we're not getting adequate outcomes. It's not ready for regular diagnostic diagnosis at the moment. And then because it's a PCR test, we would only be able to identify areas where we know where there's clarithromycin. So if we're looking at this gene, the 23S RNA gene, where the resistance is mostly, but if you can also get resistance in other areas, so you can also sometimes miss it. So again, complicating diagnosis, extending time in hospitals, more invasive investigations that need to happen. So I think we'll spend the rest of the talk going on the Enterobacterales. I think this is the E. coli's, Klebsiellas, Enterobacters. This is, I think, that's having the most impact clinically. So the main problem in this group of gram-negative bacteria is that they are found everywhere. So everyone has them in their gut. the resistance can spread quite quickly amongst them through that conjugation and spreading of plasmids. The difficulty with these things is, Staph aureus will only really spread a plasmid to another Staph aureus. So if you can control that organism itself, you can kind of control the resistance, which is why we've had so much success in the Staph aureus MRSA area. However, an E. coli can give a plasmid to a Klebsiella, can give a plasmid to an Enterobacter. So they spread it in the community and they keep it there and they hide it there. And we think we've cleared it and then it comes back. So it is quite difficult. So although we're saying the main problem is development to resistance of beta-lactams, the problem is Enterobacterales can develop resistance to multiple antibiotic classes. So they can be resistant to the fluoroquinolones, the aminoglycosides, cotrimoxazole, and all and sundry. And so what that means is our workhorses are the beta-lactams, but at the same time as our workhorses are going, our backups are disappearing. And that's because most of these resistance mechanisms are co-housed on a single plasmid. There's different plasmids in different areas of the world, but I won't get. So essentially, one plasmid can hold resistance to beta-lactams, which can also have the fluoroquinolones, can also have the aminoglycoside resistance genes, and that gets quickly shared amongst the bacterial community. And this is just to show resistance is not a new thing. It's a property of the bacteria from the moment we've introduced antibiotics at the top. Resistance has developed almost. The scary thing now is that either we're identifying it quicker or it's happening quicker. This time period from introduction to identifying resistance is getting shorter, but I think it's because we're actually identifying it sooner, not necessarily because the bacteria are evolving resistance quicker. So yeah, just to give the rundown. So initially penicillins were introduced. Penicillins themselves didn't have great gram-negative cover, but then, we have scientists and the scientists modified it to give you aminopenicillins, which is ampicillin and amoxi, and uridopenicillin, which is piperacillin, or the pip of piptaz, which had more broad spectrum, covered more of the gram negatives. And what did they do? They created beta-lactamases, and those beta-lactamases broke down these organisms. So then we were like, okay, we're in a race. We need to get something to treat this. And so then we found the first and second generation cephalosporins. So that's your first is like your cefazolin and cefalexin. Second is cefuroxime. And then we also thought, so if they're broken down by beta-lactamases, let's find something that inhibits the beta-lactamase. So we found a beta-lactamase inhibitor. So this would be your co-amoxiclav. So it's your amoxicillin plus your beta-lactamase inhibitor clavulanic acid, or your piperacillin with its beta-lactamase inhibitor tazobactam. And so that helped us for a while. And then the bacteria were like, oh, okay, that's another challenge, and evolved resistance to all these options as well. And then we developed extended spectrum cephalosporins. We might know this better as third generation cephalosporins, so ceftriaxone, cefotaxime, ceftazidime. And again, we were in the lead. We were winning. Patients were doing well, and the bacteria went, okay, we'll evolve, and then we evolved resistance to those, and that's what we called our ESBL beta-lactamases, or our extended spectrum beta-lactamases. And so then, luckily, we had our carbapenems in our back pocket, and we were sure that carbapenem resistance would not come about. And of course, in the late 90s, early 2000s, what did we get? We get carbapenemases, beta-lactams that break down carbapenems. So this is a plate. Like I said, it's just diffusion. So this is showing a resistance mechanisms that we call inhibitor 10. Common in patients that get recurrent urinary tract infections and are treated repeatedly with co-amoxiclav. So what you're seeing here is resistance to ampicillin, this AP. This zone size around co-amoxiclav here, which is AMC and piptaz, these zone sizes are too small. Those are resistance, but luckily we still have our ceftriaxone, this CTX. Cefuroxime here is borderline, and then our carbapenems, erta and imipenem are still susceptible, if you think that's interesting. So one of those critical organisms is our ceftriaxone resistant Enterobacterales. So there's two main mechanisms that they get resistance: extended spectrum beta lactamases and AMP-C production. We'll first talk about the extended spectrum beta lactamases. That's when you start getting reports like this: resistant, 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 resistant. Only sensitive to your carbapenems, your imipenem, mira, and urta, and dori. And if you're lucky, you've still got some other options to use depending on the site of infection. So now, if you had a patient that's in ICU with sepsis and needs systemic therapy, amikacin, gentamicin on their own, not really options. You can use the ciprofloxacin, and you're not even going to look at fosfomycin and nitrofurantoin for that. So even though it looks like there's lots of S's left based on your clinical syndrome, you could be in a difficult situation. Whereas here, if you have a outpatient who has a urinary tract infection, and this is the result that you've got back, so now it's an outpatient. You're not going to use carbapenems. You're not going to use injectable amikacin. So you back down to Cipro, Cotrizgon, phosphor, and nitrofurantoin. So just a bit of the science. So these extended spectrum beta lactamases were initially modified narrow spectrum beta lactamases. And then there's this one called CTXM. So it just stands for cefotaxime-Munich, because that's where it was found. And like I said, also plasmid mediated. And the area of treatment has had a bit of controversy in infectious diseases lately. There was talk of, can you use piperacillin, tazobactam, or meropenem? And so what this Marino trial has shown is that piperacillin, tazobactam has suboptimal outcomes to the carbapenem. So, it's already pushing you to quite broad spectrum. If you have this resistance mechanism, you really have to jump to your carbapenems in terms of the beta lactamases and what you use to treat in severe situations. In other situations, you could be using other antibiotics, as we discussed. So then there's this AMP-C mechanism. Now that I'm looking at it, I'm realizing I'm probably giving too much details here. But essentially, this can be in two forms. It can either be on the chromosome of the bacteria, and those are certain bacteria, or it can be on the plasmid. So when it's on the chromosome, we won't always pick it up when we do the testing. It likes to hide away because it needs to be induced to do it. We've now got newer testing which helps us to identify it. But just to be aware that might be the case. If it's plasmid mediated, we often will pick it up because it produces it. So those bacteria that have it in the chromosome where there's a high risk of induction. So, it's not always useless to know bacteria names. So Enterobacter cloacae, Citrobacter forindii, and Klebsiella aerogenes. If you see these names, you need to be aware there's something going on with these bacteria. And if you don't remember, you don't have to remember, just call and discuss with your friendly microbiologist. And so there are some others, but we can pick those up. And so it's really based on how the antibiotics induce, which also affects how you're going to treat. So when we say it's a good substrate, we say the enzyme can break it down quickly and very well. So you can't use these ones to treat, because no matter at what level the enzyme is present, it's going to break them down and not going to be able to use it. So these are good substrates, or our extended spectrum beta lactamases, ceftazidime, ceftriaxone, but they're weak inducers. So sometimes when you what happens is, you kind of got a patient, you start empirically on one of these third generation cephalosporins, they get better over 2 to 3 days, and then suddenly they're not doing well. And they're getting worse, and you repeat the cultures, and it's the same organism, but now it's more resistant. So that's because even though it's weak inducers, it's eventually induced it enough to get it to where the enzyme is high enough, where because it's a good substrate, it breaks it down. Then you get something like imipenem, which is a strong inducer, but it's a poor substrate. So it doesn't matter how much imipenem you give, you can still use it to treat. And then this is obviously the sweet spot where you want to be with cefepime and meropenem being a poor substrate and a weak inducer. So where there's no other resistance mechanisms, cefepime is actually our treatment of choice for these three organisms, so we don't end up with these things, or a carbapenem. And that was done here with this Marino 2 trial that was shown. Again, they were looking at piptaz, because at one stage piptaz was considered And so you'll get comments on report like, even though it's tested sensitive, we don't recommend you to use it. Or you'll get a report where we don't even show the third generation cephalosporins, even if they're test susceptible, because they really shouldn't be used in the treatment of these. So again, limiting your treatment options for the treatment. And then just to be very annoying, so these organisms can initially look like this, but they can always later get a carbapenem resistant gene as well. So this is very complex, very important from a antibiotic choice perspective, but I think this would be something that you really would talk with your clinical microbiologist. You'd be having discussions on ward rounds. You'd have your infectious diseases doctor and your clinical pharmacologist with you. But just to be aware that there are 4 main classes, A, B, C, D. The most difficult to treat in the clinical scenario would be class B. There's not many options to treat these. The treatment options have gone through quite a revolution with the new antibiotics that are available. And I hope I don't go through it too quickly while we have a discussion. So this is something that we see in the labs. As you can see, we've got growth right up to these discs, and these zones are too small. And we go, oh no, what's going on here? And then hopefully we have something like this. So this meropenem zone is too small, so it's still showing that it's resistant. But we do have some options here. We've got cotrimoxazole, your aminoglycosides if it's a urinary tract infection, and then this new antibiotic called ceftazidime avibactam, or the brand name in South Africa currently is Zabaxa. But more often than not, we get something like this. And this is due to the epidemiology of the carbapenemases in South Africa. So I'm just going to go back to this one. So remember I said B is extremely difficult to treat. So B is quite a fair amount of our carbapenemases in South Africa. So A is what the carbapenemase that is called a KPC. So Klebsiella pneumonia carbapenemase, more common in the United States. In South Africa, we have a B class enzyme, which is called NDM or NDM1, and we have a D class enzyme, which is called OXA48. And these can be also found together on one plasmid, which often complicates our treatment options. So like I said, we got some new antibiotics. Here's this one called ceftazidime avibactam. The brand name is Zabaxa. It's a new beta-lactamase inhibitor. So the ceftazidime is an old beta-lactam, but the inhibitor is avibactam. And, luckily for us, avibactam inhibits the extended spectrum beta-lactamases. It inhibits the MCs. It inhibits group A carbapenemases and some of the group D. Luckily, what we have, OXA48, but it does not inhibit NDMs. So what about our NDM producing bacteria? So what we need to treat these ones is Aztreonam avibactam. That's because Aztreonam is stable against these NDM organisms, but it's broken down by the ESBLs that are present. But the avibactam blocks the ESBLs and the MCs. So like I said, we don't have Aztreonam avibactam in South Africa if we're treating these organisms in severe infections. So we give ceftazidime avibactam, which is Zabaxa, and then you've got a section 21 Aztreonam, because Aztreonam is not available, to make our own Aztreonam avibactam. So this complicates, you've got 2 antibiotics running at the same time as infusions, usually through the same port. These, we have to make sure that these things go together. Otherwise, you can't give one, then the other, then you lose this beta-lactamase inhibitor effect that we're trying to make with the Aztreonam avibactam. So this is just a meme in the infectious disease microbiology world. You have an NDM producing bacteria, thinks it's invincible, and then we found Aztreonam avibactam in our roundabout way to get through the visor. So I've left out lots of details in terms of treatment of carbapenem-resistant Enterobacterales. I'm not going to read this table out. I think we're getting a bit short for time. But ECMA is the European Society and ITS is the American Society. They're very similar, but I think where we sit in with most of our stuff is severe infections where you don't have access to these new antibiotics. And we'll discuss that a little bit. And this is where the colistin and polymyxin B comes in, and using tigecycline in weird ways if we've got it, and hoping and praying that other antibiotics are susceptible. Then another enemy of ours is Pseudomonas aeruginosa. So remember we spoke about intrinsic resistant. Well, Pseudomonas is intrinsically resistant to lots of antibiotics. So from the get-go, this is our limited antibiotic armamentarium against Pseudomonas. That's it. And if you look at this, you might recognize that there's only one oral option. As soon as ciprofloxacin or levofloxacin is gone, there are no oral options for Pseudomonas aeruginosa available. Fosfomycin used to be thought to be susceptible, but only in UTIs. Even then, it's very difficult. And the difficulty thing here is there's no predictability in Pseudomonas aeruginosa's treatment. And so if you work in critical care, you'll often hear if you're suspecting a Pseudomonas aeruginosa infection, or you get the ID of Pseudomonas on a sample and you're treating it for your infections, you always start with 2 antibiotics from 2 classes because we cannot predict which one is going to be your resistance. And once you've got the resistance pattern, you target your Pseudomonas aeruginosa based on that. Luckily, Pseudomonas can also be a colonizer, so just because we've grown it doesn't mean we have to treat it. Again, complex diagrams just to show almost every single resistance mechanism that you could potentially get is present in Pseudomonas, from enzyme changes, breakdown of the antibiotics, pumping out, closing porins, everything is there. They're often in combination. One pump can pump out lots of things. Closing one porin can let in one carbapenem, but not the other carbapenem, which is why you can get these weird and wonderful resistance patterns. This is ceftolozane tazobactam, the antibiotic that was the new one that's come in. Sorry, this is called Zabaxa. The other one is Zavicefta. I apologize for that incorrect naming. So it's a new cephalosporin targeted with tazobactam. It's designed specifically to penetrate Pseudomonas aeruginosa's membrane, even when there's loss of porins and mutations. And it's stable against AMC, which Pseudomonas has. I'm not going to go too in depth with this one. If you're reaching for ceftolozane tazobactam in the hospital environment, you probably have some experience or have already discussed with the thing. Not really to be used in an outpatient. It's only available IV. And then just ending with a quick rundown, Acinetobacter baumannii, another hospital terror. Similar to Pseudomonas aeruginosa in that it can develop multiple resistance mechanisms to almost all its antibiotics. Also already has some intrinsic resistance. Although there are some extra antibiotics that we can use here, tigecycline, cotrimoxazole, treatment with ampicillobactam, and the testing is extremely interesting. But it can be a lecture all on itself, and if anyone has questions about it, we can talk about it afterwards. But the thing is, this can initially be sensitive, and it very rapidly develops resistance. And again, treatment prediction is difficult, and this is where you're probably reaching most often for colistin in our environment, because even those new antibiotics, ceftazidime avibactam, also known as Zavicefta, and ceftolozane tazobactam Zabaxa, don't work. Already not available for A. baumannii. And then just a little talk, because we do use it. Colistin is an old antibiotic. When you give it as colistin, as we do in South Africa, you give it as a prodrug, which is why it has such a huge loading dose. Causes renal dysfunction on its own, and renal dysfunction impacts how you dose it. Currently, our last resort antibiotic really shouldn't be started first line or empiric on anyone. And there is resistance developing with these mobile colistin region genes. Luckily, none in South Africa in humans at the moment. And then just a quick overview of new antibiotics, like we've been saying, what's available in South Africa: ceftazidime avibactam, ceftolozane tazobactam. So what's available elsewhere? These ones, meropenem, vaborbactam, imipenem, relibactam. These ones won't really have a place in the South African market just based on our epidemiology. If anyone has read some stuff about cefidoracol, this is what's called a Trojan horse antibiotic. It uses a very unique mechanism to get into bacteria. However, in treatment studies, it hasn't been as great as we were hoping it to be to save us from the NDM scourge. This one, Gerlobactam sulbactam, is very specific for Acinetobacter baumannii. We haven't yet tried to get it into the country in some of our dire situations, and it's only registered for treatment of multi-drug resistant Acinetobacter baumannii. Aztreonam avibactam is no longer in development. It is now available elsewhere. And then these are just some other combinations of beta-lactams, beta-lactamase inhibitors. As you can see, not many new mechanisms. It's really just by combining a beta-lactam with a beta-lactamase inhibitor. And then, yeah, just in conclusion, antibiotic resistance will develop no matter what we give. The bacteria have been evolving it for thousands of years. Unfortunately, antibiotic resistance limits our antibiotic treatment choices. And so we do need to prevent the spread of antimicrobial resistance, but that's an IPC, IMR talk. And it's a rapidly developing area with many new antibiotics. And just remember, it doesn't just limit choices, but it has impacts on patients. Patients are in the hospital for longer, patients have worse outcomes, longer treatment courses, increased cost to the healthcare system, and all of that stuff. And if we don't get on top of antibiotic resistance, it's really going to cancel our modern medicine developing ability. I don't think we realize how much we depend on antibiotics. And that's it. And if there's any discussion, if anyone's still around, happy to talk.
Yes, Doc, there are still many people around. We still have over people listening on stage. We had 135. Thank you very much. You can the hearts and the thumbs up that is on the screen and the applause. I think it was a good revision for some of us, and also I hope it did the names of the new antibiotics, antimicrobials that we had today. I'm sure a lot of them were new to a lot of people as well. I hope they didn't scare all of us, but instead they should they should actually encourage us to know more. I think because we really need to know more about antibiotics. They could be some of the most prescribed agents, I think, in the country, if you look at it, for all specialists and general practitioners. For some reason or other, I think people tend to prescribe a lot of antibiotics, and we may be prescribing them without much knowledge about enough microbiology. But I think you've instilled some interest in topic number one of microbiology, and also the fact that we need to avoid contributing to the increase in antimicrobial resistance in the country. If anyone would like to ask a question, all you have to do is just to raise your electronic hand, and we'll be on the lookout for hands that may be raised. Otherwise, you may even type your question, your comment in the chat box if you'd like. But as people are going to ask questions, I think I've got one or two questions. Dr. Le Grange, the first one, your topic, why gram-negative resistance, and you didn't choose, for instance, gram-positive resistance. Does it mean that it doesn't occur at all?
No, gram-positive resistance really, it does occur. It is a problem. If you went through if anyone was able to read that WHO priority list, you'll see in the middle column, there's quite a lot of gram-positive organisms there. Maybe because of the world that I'm in, but it feels like in the early 2000s, 2010, around about there was a big emphasis on MRSA organisms, which is a gram-positive resistance in strep pneumo. And that's when we got all our new antibiotics to cover gram-positive. So that's when linezolid came around, that's when daptomycin came out, tigecycline as one of our potential options. So, the gram-positives were identified, resistance was identified as a problem, and we relatively successfully approached it and tackled it. I mean, and so I think it gave us a false sense of security. And then, because looking at how resistance moves in the gram positives, it's a little bit of a slower process. It's not as promiscuous amongst the bacterial communities. And so I think we were taken a little aback as a healthcare community how fast gram-negative resistance came. And I think there's still a bit of a lack of awareness of it out there. It's not infrequent that I get a phone call from someone who works in the community, because most of these hospitals currently are situated in the hospital environment, but you get a call from someone in the community and they're like, there's absolutely no oral option to treat this patient. Are you saying if I want to treat this patient, I have to admit this patient? And we're saying, and so it's taking us back to an evaluation based, because now we go back and we say, okay, you've got this urine which has come back with this resistant isolate, but does your patient actually have a urinary tract infection? Does this patient, why did you take this urine? And then someone will say, oh no, I took the urine because the patient has back pain. And you're like, well, urine isn't an investigation for back pain. Urine is an investigation for patients that present with urinary tract symptoms. And so in the past, a patient would come with back pain, have a fully sensitive bacteria, you gave the antibiotic, patient never came back to you, you think you've done something well, meanwhile the patient's gone to the doctor down the street because they still have back pain. And so these are difficulties and changes in our things that need to happen. Okay, that's a bit of a roundabout way, but yes, there is resistance in gram positives.
Okay. There's a question, would the use of a broad spectrum antibiotic be the preferred option when treating empirically, preferably, of course, after taking a sample, swab or something for MCNS, microscopic culture and sensitivity? If you were treating empirically, would you advise that we choose a broad spectrum one rather than
So yeah, I mean,
one?
this is again, you really is tailored to your clinical scenario. So most of us as clinicians are giving antibiotics empirically. When a patient comes in with a community-acquired pneumonia, we are giving empiric antibiotics. We're not taking sputums, especially if they're mild or moderate, and we're treating them as outpatients. You're giving empiric antibiotics, but our empiric antibiotics is guided by our epidemiology. So, places like the NICD or anyone that's doing a research project, we've gone and we go, okay, community-acquired pneumonia, most community-acquired pneumonias are viruses. So do we actually need to treat from the first place? Then if we want to target the bacterial causes, it's strep pneumo, Haemophilus influenzae, Moraxella. Those are probably the big three. There's a couple of others. And most of those in South Africa, in the community, are still susceptible to ampicillin and co-amoxiclav. So those should be your empiric choices. If you're going any broader than that for a community-acquired pneumonia, you are then promoting resistance, because if you give a broad spectrum antibiotics when you don't need to, it's not the bacteria that you're treating where the resistance is happening. The resistance is happening in our human guts. All those E. coli and Klebsiellas are in our guts and have been exposed to this broad spectrum antibiotic, and they are developing the resistance and keeping those plasmids in, so that and that's how it potentially develops and spreads within the community. So when would you go broad with your empiric antibiotic? Well, when you've got a patient who's in an ICU, who's been hospital bound, and the epidemiology of your ICU is that you have ESBLs, AMPCs, potential carbapenemases, and that's when you would go with a broad spectrum carbapenem, but definitely not someone that's come in from the community in your casualty, who's never had a hospital exposure. If a bacteria is susceptible to ampicillin, ampicillin is as effective on that bacteria as your carbapenem. Your carbapenem is not more effective than ampicillin on a susceptible bacteria. The reason why we have to go with the carbapenems is because in certain situations, it's because the bacteria have developed resistance to the ampicillin, and the ampicillin is more effective. But if it is susceptible, there's no benefit going for the carbapenem over ampicillin in a susceptible organism. I hope that helped or answered your question.
Yeah. Okay. There's another question. It says, should clinicians interact more closely? Clinicians, in this case, referring those who are sitting in the wards, ICUs, and so on. Should they be interacting more closely with the pathologist with which they share a patient? Because I think when a clinician sends a sample to the laboratory, whether it's a microbiologist or to a microbiologist or a histopathologist, I think the clinician is, by extension, sharing the management of that patient now with the pathologist. But they hardly ever talk to each other, as we know. I know in some cases they do, but and the pathologists, some of the pathologists do ward rounds with clinicians. But do you think there's enough interaction in treating, especially patients who are very ill, and between clinicians and microbiologists, or what do you think?
No, I think there should always be communication. The more people we can get and be multidisciplinary in the treatment of patient happy. We're always happy to take a phone call, or if we close by, come to the ward rounds. We have some good relationships in certain areas. We're also fully aware that it's ultimately the clinician's decision. So we are in an advisory role, and we're always willing to give advice. And that must, because we don't know the full. As a pathologist, we don't know the full everything of the patient. We don't know allergies, we don't know previous treatment. Some clinicians get annoyed when we ask all these questions because it's information that's needed to help with the treatment of the patient. So yeah, always willing to interact, and it doesn't necessarily have to only be in sick patients. There can sometimes be at the GPs an odd bacterial name or anything that is, or even interpretations of syphilis serology, STIs, where it's difficult. There's many bacteria on our molecular panels which are new, and if people just want to discuss them or where they sit, sometimes we don't know how important a Mycoplasma genitalium is. Is it a colonizer? Is it causing the disease? And we need to have that discussion. So always available to speak to your friendly microbiologist out there.
So you encourage clinicians, GPs, specialists, whatever, to not to hesitate if they need to call their pathologist. Usually all pathology reports have at the bottom the name of the actual pathologist who wrote the report. And then there is, of course, a telephone number. So they could do that. Maybe they should do it more often. Is that what you're saying?
Yeah, they're welcome. They're welcome to give us a call. Obviously, I mean, if it's something that they know and they feel that they've got it under control, then they don't have to call. But if it's if there's any queries or anything to discuss, more than welcome to.
Okay. Dr. Azundini Gilbert Malauzi is asking a question. It says, when treating these atypical bacterial infections, what is your advice on the duration of treatment, or will that be dependent on the biomarkers?
So again, it's dependent on how ill your patient is. So what's atypical bacterial infections? They're called atypical because they present atypical, but the atypical bacteria are often intracellular organisms. So, and they sometimes lack a cell wall. So things like beta-lactams don't work. So you need something that targets something that's intracellular of the bacteria. So things like a macrolide, doxycycline, levo or ciprofloxacin. So that'll be your target. And then the duration is sometimes influenced by the bacteria, which we cannot grow in the lab. So this is where the molecular tests come in. So you'll do an atypical test panel on a sputum, and then we'll say there's mycoplasma, there's chlamydia, there's legionella, and then depending on those. But if it's a simple outpatient cap or pneumonia, and you've given your 3 days of azithromycin and the patient has responded, the 3 days is enough. You've given 3 days of azithromycin, but azithromycin's got a very long half-life. and probably stays in the system for 5 to 7 days. So the treatment duration is 5 to 7 days with the other antibiotic choices if you can't use azithromycin for 3 days. In terms of atypicals in the genital tract, in terms of STIs, the movement in the guidelines is really to treat with doxycycline 100 milligrams twice a day for a week. Yeah. We're moving away from high dose, single dose macrolide.
The following question might be maybe outside your topic of tonight a little bit, but I mean, we speak a lot about antibiotic amongst the antimicrobials. We speak a lot about antibiotic resistance. What about antifungal resistance? Does it occur a lot and to varying extents as well, antifungal resistance?
So antifungal resistance definitely happens. It is a problem. So there's two areas where it's most difficult. So in your severely sick ICU patients who have candidemias, the resistant candida are very troublesome, particularly in South Africa, something called Candida auris. It's a worldwide organism. It's causing problems worldwide, particularly after the COVID pandemic. Unfortunately, Johannesburg is like ground zero for Candida auris. We probably have more Candida auris than the majority of the world combined. And it is a multi-drug resistant yeast. So it's resistant almost invariably to fluconazole, which is our workhorse drinks and other azoles, which means we have to then go with broad spectrum and not broad spectrum, but more expensive antifungals like echinocandins or amphotericin B, to which it can also develop resistance depending on the clinical outcomes. So once you've got a Candida auris that is resistant to all three of your antifungal options, you're not really left with much to treat your patient other than hope and prayers and a few other very expensive, difficult to obtain antifungals, which I'm not going to talk about here because you talk about it on a per patient basis. And then the other aspect is there's been a couple of cases described in KZN is our trichophyton, which causes superficial skin infections like ringworm and stuff. There is one that has developed resistance to our first line treatment, and patients present with long cases, and they're again difficult to diagnose, has to go to NICD for molecular testing, and then they suffer with these skin lesions. It's not like a simple flaky bit of skin. It's painful red lesions which impact patients' lives simply due to antifungal, not simply due, but which is prolonged due to antifungal resistance and difficult to obtain treatment. Yeah, so it definitely does exist and we should be aware of it. Luckily, our cryptococcal neoformans hasn't yet shown any resistance to our first line treatment for cryptococcal meningitis in our HIV patients.
Thank you very much for that. I think the last question that I have written there is you spoke about colistin and being our last what do you call it, weapon against multi-resistance, if I may call it that way, in the country at the moment. What happens if there's any resistance is noticed? I think I hear you saying there's no resistance at all to colistin at the moment in the country.
No, there is resistance. You can develop resistance to colistin. So first of all, remember we spoke about intrinsic resistance. So certain organisms are intrinsically resistant to colistin. So I don't want to bore people with names. So things like Serratia, Marcescens, Burkholderia, these are organisms that cause infections in quite select groups of patients. Your Proteus organisms, which are quite common, Providentias, they are all intrinsically resistant to colistin. Doesn't matter how much colistin you give, they're not going to be treated with colistin. Also, colistin doesn't treat any gram-positive organism. Having said that, we are seeing resistance in Abamani's, Klebsiellas, all of that, especially patients that have been on prolonged treatment courses. I probably didn't clear it or make it clarified. What we're not seeing is a mobile plasmid which spreads quickly amongst the bacterial community. So we're not seeing a mobile genetic element which spreads the infection. These organisms are developing infection through exposure, developing mutations, and then they become resistant that way. And so the main way that their resistance will spread is only if that bacteria grows and is transferred from a patient to a patient. Whereas the mobile colistin regions, so the MCR1 to whatever genes, they can spread within the bacterial community very quickly. So if they're in a patient, then they spread amongst those bacteria community in the patient. And that if one of those gets out, it could potentially spread in the environment and spread out very quickly. Particularly, it's more concerning to see an MCR gene in agricultural regions because cows and animals aren't keeping their poop separate away from their food and stuff like that.
Thank you very much. I think that was the last question that I jotted down. I don't see any more questions. I think I'm just always gets impressed with the amount of knowledge and expertise that we have in the country. Thank you very much. I'm going to give the mic over to my colleague, Chief Medical Officer, Dr. Burton Shinas, just to thank you properly and to thank all attendees. Over to you, Dr. Burton.
Thank you so very much, Dr. Kinashi. You know, I was, Dr. Le Grange, I was trying to figure out, is it Grange or Le Grange? How did you feel comfortable pronouncing it?
I don't mind too much how people pronounce it, but I pronounce it Le Grange. So, but yeah, I'll take whatever people say.
Thank you so much for taking us back to med school. Just as I was about to get onto the call, my daughter asked me, "What's a gram positive? What's a gram negative?" Bacteria. And I gotta brag, you know, she was on her way back from the National Rhythmic Gymnastics competition, you know, so she won there. So just for those of you that are listening, I can brag and boast a little bit. So thank you for the presentation and the thorough way in which you presented it. I know you were already quite eager to do it last week. So thank you so much for being willing to do that. And as Dr. Kinoshi said, we know there are specialists and colleagues that are experts in their field and have a wealth of knowledge. So please do volunteer, put up your hands or nominate each other to participate in these webinar sessions. The webinars, as you know, are sponsored by Clinix, the health group. So I want to say a special thank you to the Clinix Health Group. And then we have people that are in the background every week, Tolagele and Sam of Viwe, that are supporting and ensuring that everything works successfully. You met them earlier on in the day, Dr. Le Grange. And so for all the participants who are so dedicated and committed every single week, and for the support, the questions, and for the ongoing interest, we really, really do appreciate your participation and for keeping the webinars excited and relevant. So going forward, Dr. Kinoshi, thank you so much once more. It's good to have you back from your trip to Morocco. We missed you, and I'm sure everybody, you are more popular than me. So yeah, I think you're not going to get out of escaping doing these presentations. Thank you, Dr. Kinoshi, and thank you, Dr. Le Grange.
Thank you very much, Burton. We will meet again next week, Thursday, with yet another webinar. And let me tell you, because this is Mental Health Care Month, one of the 3 webinars that are still coming this month, I think it's 3, is going to be on psychiatry. But I think we have a webinar every week lined for the next 4 or 5 weeks. So please watch out for our webinar posters for next week. Thank you very much and good night to everyone.
Thank you very much. Have a good evening.
Thank you. Thank you, Michael.